Good afternoon, ladies and gentlemen. You're most welcome for today's Art of Birth Session 2, organized by the Ministry of Health, Uganda, in conjunction with the Reproductive and Child Health, together with the CD Global Health. In the house, we have our experts. And the first expert we have here is Agnes Chikumino, neonatal nurse from Mulago Specialized Women and Neonatal Hospital. Agnes, you're most welcome. Another expert in the house, we have Demoy Jennifer Christobel. Christobel is one of the pediatricians from Mulago Specialized Women and Neonatal Hospital. Jennifer, you're most welcome. Then we have online Eunice Akelo, who is our case presenter. And Eunice will be presenting online. You are most welcome, Eunice. Eunice is a junior house officer from Soroti Regional Referral Hospital. Another person online who is going to help us in answering the chats in the question is Idris Mubiru. Idris is consultant pediatrician from Kawempe National Referral Hospital. Idris, you are most welcome to this session. And our session will run like this. We shall have the main topic for today is my baby fine? This is the question always asked by the mothers, by our caregivers. And we have to give them the answer. Is my baby well? Is my baby fine? That is the main topic for today. And the subtopics for today, we have the first presenter, Agnes, will take us through scoring a baby at birth. And we know this is very, very important. We score the baby at 1 minute, we score the baby at 5 minutes, and at 10 minutes. So these scores are very important. We need to update ourselves. So she will also take us through identifying and classifying the baby. Then Jennifer will take us through, Dr. Jennifer will take us through triage of neonates after birth. And we know triaging is very, very important to rule out danger signs in these neonates and which baby really to be acted or worked upon first. This is very important. She will also take us through this update. Then Dr. Jennifer will also take us through newborn head-to-toe examination. And we have really found out that this is a big challenge in most of these facilities around our country. Then we shall go through the session discussion questions and answer and closing remarks with a post-test. We shall have a pre-test at the beginning and then a post-test. So be ready to ask, and then you will also give us the answer at the end of this session. So thank you very much. I take this opportunity to invite Agnes, the first presenter. I beg your pardon, since we talked about pre-test, please, we have our pre-test there on the chat. May you fill this pre-test within 1 minute or 2, then we shall be done. Thank you. Then the pre-test, The second thing we are going to do, the another activity is now to write your expectations. What are your expectations for this session? Write them in the chat. Thank you. Okay, I think we are done with our expectations. And those ones who have not yet finished answering the polling questions, please, you can continue answering the questions as we proceed. So at this juncture, I'll be requesting Eunice to be ready with the case presentation. Are we getting challenges in filling the poll? The online members, are we filling the poll? So we are having you some 3 minutes. It seems there are some challenges in filling the poll. Please, we are having you 3 minutes to do that. Thank you. Meanwhile, Dr. Eunice, you can just keep on and we shall tell you when to begin. So I think we are done with our poll. So the next activity is now to request Eunice to take us through the case study. Eunice, you're most welcome. Is Dr. Eunice online?
Yes, please. Hello.
Okay. You're welcome.
Am I loud?
Yes, loud and clear.
Yes, please. Thank you, the moderator. Thank you, everyone, for this time that we are having to present. And I know at the end of the session, we are going to be able to answer our clients. Is my baby okay? Is my baby fine? That question we are going to answer our patients, our mothers confidently after this session. Hello, am I heard? Am I clear? Yes, moderator. Am I okay? Am I clear?
Yes, you are very clear. Go ahead.
Okay, I'm going to go straight to the case. In this case, we examined the child, the newborn, immediately after birth. Then the second examination was done within 1 hour, then 6 to 24 hours, and then 48 to 72 hours to confirm whether the child is fine for discharge. I am Akelo Eunice, JHO, Soroti Regional Referral Hospital, and I'm going to take us through the case. We received baby of AB at 2 days old, was born on 14th May 2025. The assessment was done as I had told us, from birth up to 48 hours, but the last was 72 hours. Was born at 32 weeks by safe vertex delivery. Apgar score was 6 at 1 minute and then 9 at 5 minutes. The mother is a 22-year-old, para 1 plus 2. She reported of having 2 abortions at early trimester due to febrile illness that was managed as malaria UTI. She attended 4 antenatal visits. 1 was in the first trimester. She is HIV, syphilis negative, blood group B positive. She never had any obstetric ultrasound scan done. During pregnancy, she was on medications, iron, folic acid. She was dewormed. She was taking monthly Fansidar. However, she reported febrile illnesses during her pregnancy that was managed as malaria UTI. She reported of having a foul-smelling vaginal discharge for 1 month, which was in her late pregnancy. She said it was 1 month prior to labor onset. She had a spontaneous labor onset. Membranes ruptured 30 minutes before delivery, and she reported that the child had a weak cry at delivery. Apgar score on delivery, the scores were as follows. At 1 minute, appearance was 1. That's our baby was having pink body, blue extremities. Pulse was 2, that is greater than 100 beats per minute. Agreements was at 1. The child had minimal agreements on stimulation. Activity was 1. The child had small flexion, had some flexion of limbs. Hello, are we together? Hello?
Go ahead, we are together. You are clear.
Okay, please, moderator. Respiration was at 1. The child had slow, irregular breath. The total was 6, which was moderate birth asphyxia. So there was moderate depression. At that time, the action we did, the airway was clear, and we had gentle stimulation of the baby. We gave supplemental oxygen, and then we decided to transfer the child. We planned to transfer the neonate to NICU for close monitoring. Now, at 5 minutes, the child was completely pink, scoring 2. Pulse was greater than 100 beats per minute, scoring 2. The child would cry on stimulation, scoring 2. However, activity was still, the child was still having minimal activity, scoring 1. Respiration was 2, had good regular breath, and we graded our child as in good condition and responded to resuscitation. So our recommendation was to continue monitoring in NICU. The parameters, we took vital observation, and these were the parameters we took. The heart rate was at 150 beats per minute, which was normal. Respiration was 50, which was normal. Temperature was 36.8. Child was on radiant warmer, and we maintained that. SpO2 was 96 and was stable. The weight was 1.585 kilograms, which was low. So our child had a low birth weight. Head circumference was 29 centimeters. This head circumference is low. The normal head circumference for neonate is at 33 to 35 centimeters. But this one was 29 centimeters. But given that the child was a premature, it was normal for the gestation age. The length was 42 centimeters, which was normal for gestational age. But normal newborns, their lengths are more than that. Chest circumference was 27 centimeters, which was normal for the gestation age. We did a Ballot score to examine our baby for maturity. So we did the muscular maturity and physical maturity, and that was the score. The posture was at 3, square windows of the wrist was at 0, arm recoil 4, popliteal angle 4, scarf signs 3, head to ear 4, and the total was 18. For physical maturity, skin was at 1, lanugo -1, plantar surface 3, breast 2, eye, ear 2, genitals 0, then total was 7. Grand total was 25, which corresponds to 34 weeks of gestation. So gestational age of our neonate by date was 32 weeks. By ultrasound scan, we never did ultrasound scan. Then by physical exam, by Ballot score, it was 34 weeks. Hello, are we still together? Hello, moderator.
Go ahead.
Okay,
Yeah,
we did head-to-toe examination. The head, there was no molding, anterior fontanelle soft and flat. Sorry, excuse me. Then there was no swelling. The eyes were closing intermittently, reacts to light, and no discharge. Ears, the pinners were soft and folded, no discharge. Nose were patterned, and there was no discharge. The mouth there was intact palate. The tongue was normal. However, the child had poor suckling. The neck, there were no swellings and no mass. The chest, equal movement, bilateral equal hair entry. Heart sounds 1 and 2, normal, no added sounds. Abdomen, normal, fullness, soft. Umbilical stump was clean and fresh. And then the anal, the anus was patterned. No good. Then genitourinary system. There was prominent labia minora, whitish PV discharge, which was a leukorrhea. Extremities, there was spontaneous movement, although there was some reduced tone, no deformities or birth defect. The skin was pink, no vernix caseosa, no lanugo, no rash or skin lesions. Neurological exam, the moral, rooting, grasping, and then sucking reflex were present. But however, we noted that the suckling reflex was reduced. Now, the investigation that we did RBS, which was normal, within normal range. It was 4.9 millimoles per liter. In summary, we examined a premature at 32 weeks of gestation by dates with low birth weight, that is at 1.585 kilograms, was feeding by NG tube, a good postnatal transition with improving tone and reflexes. So the condition was stable. We planned to continue NGT feeding with the express breast milk, monitor vitals, monitor temperature, educate the mother on kangaroo and feeding. We gave prophylactic antibiotics, daily caffeine. At 48 hours, we re-examined the patient, the neonate. All the vitals were within normal range. There were no major concern. So we planned to remove the NGT and we initiate exclusive breastfeeding. Attachment, we continued kangaroo, and then we planned to monitor the neonate for more 24 hours, and then planned for discharge if the neonate remained stable. At 72 hours, that is 3 days, everything was unremarkable. We discharged the neonate home on syrup Grovit and Imofort, and then we gave a return date of 1 month. Thank you for listening.
Thank you very much, Dr. Eunice. I'd like to have the House, you have listened very well to this case presentation. Is there any reaction? Any reaction in the House to the case presentation? Yes, you can unmute and give your submission, or you can write in the chat. Any reaction to the case presentation can be written either on the chat, or you can unmute and give your submission. Who want to give any submission, put up your hand and you will be unmuted. Any submission, put up your hand or write in the chat. It seems there are no submissions, so we can go ahead. So thank you very much, Dr. Eunice, for the presentation, and everyone for listening carefully. So now the next activity, we are going now to learn to listen from our neonatal nurse from Mulago Specialized Women and Neonatal Hospital, that is Agnes Tilkumino. Agnes, you're most welcome.
Thank you, Alice. Good afternoon, everyone. Everybody introduced. I'm happy to be here for this presentation, which is looking at assessment of the newborn at birth. And the outline, presentation outline, I'll briefly introduce what we are going to look at, then go straight on how to score a baby at birth. Then later, talk about how we identify these babies, classify them, then take appropriate care. So every neonate needs a quick assessment at birth to determine whether there is need for resuscitation and act within the golden minute. This should be done before assessing the APGAR score, and the healthcare providers should not wait for APGAR score to determine the need for resuscitation, the need to help this baby to breathe, because our main question was, is my baby breathing? So don't wait for that, but quickly assess and be able to help this baby to breathe. If a baby is not breathing, ensure you initiate positive pressure ventilation before the end of 1 minute. So the question goes, is my baby breathing, as we initially said? So if your baby is breathing and your answer is yes, you will quickly assess airway. Is the airway clear? Is the baby breathing well? And then the saturation. Then you give the appropriate treatment. But in case this baby is not breathing and your answer is no, you need to resuscitate. Don't wait. Quickly dry the baby, clear the airway, and ventilate before the end of 1 minute. Because this will help the baby instead of dwelling to score. Remembering that our score is normally done at 1 minute, 5 and 10 minutes. So it is always good that you ensure the baby is breathing before you do the rest of the assessment. So scoring a baby at birth requires knowledge of what to score, a skill of how it is done, and how and when to do it. This is very important. You have to have the knowledge of what you're looking for, like Eunice has just elaborated. Looking at the skin color and the rest. How it is done, we shall see. Then when to do it, as we say, at 1 minute, 5 minutes, and then at 10 minutes. APGAR score is a tool healthcare providers use to assess the baby, how the baby is doing at birth. It lets providers determine what baby might need, lets the providers determine what the baby might. Sorry, I was just elaborating that when you do the APGAR score, it lets you quickly determine if a baby might need extra care. One thing it can't do is to predict the intelligence, how they will develop, or their health. It is not the only thing providers rely on when determining the care the baby needs. So what am I trying to say? After scoring the baby, you need to do extra things so that this baby is wholesomely taken care of according to the needs you found out. So we just want to look back. Who invented the APGAR score? Dr. Virginia APGAR, an anesthesiologist, first described it in the 1952, then published a research paper in 1953. However, the scoring system did not use the letters of her name, but later in 1962, there was a pair of pediatricians who started using her name, which made the scoring easy. So this table is just showing us what are those different things we look at and what do they represent as you score this baby. The first one is how the baby appears. So it will score 0, 1, and 2. So if your baby appears blue and is pale on appearance, then it scores a 0. But if your baby's body is pink and the limbs are blue, baby scores a 1. Then if the whole body is pink, including the extremities, that baby scores 2. That is appearance. Then pulse. That is the heart rate. If it is absent, then that is a 0. If it is less than 100 beats per minute, then the baby scores a 1. But if it's more than 100 beats per minute, the baby scores a 2. Then we go to Grimace. Grimace is response to irritability and stimuli if you stimulate the baby. If there's no response, the baby scores a 0. If there's some grimace, like a cry, some sort of noise, the baby scores a 1. Then if there is coughing or crying, the baby scores a 2. Activity. If the baby is limp, just floppy, then that is a 0. If the baby is weak, not moving so actively and vigilantly, the baby scores a 1. But if baby strong is able to move the hands and the legs, the rest, the whole body, baby scores a 2. Last, about respiration, the breathing. If it is absent, that is a 0. If it is irregular or slow, baby scores a 1. But if there is good breathing, like regular breathing, baby is crying. Sometimes people look for crying, but if also baby is breathing well, like the chest and the abdomen are moving, that is a 2. Then this table is just elaborating how you score, which I've just, I think, explained in the last slide. Yeah, so how do we identify and classify this newborn? So each of the above 5 signs, that is appearance, pulse, Grimace activity, and respiration, scores from 0 to 2 as I've elaborated. So the total score is from 0 to 10. So you will classify your baby to be reassuring or doing well if the baby scores a 7 to 10 after you've totaled your score. Then it will be a 4 to 6. A 4 to 6 score is a moderately abnormal baby, you need to act. Then if it says 0 to 3, that one you need quickly to call for intervention, call for help. That is a very low score where we need to act vigilantly to help this baby to breathe. The score is done at 1 minute, as I elaborated in the table, 5 minutes. Then, if the 5 minute score is less than 7, then check at a 5 minute interval until 20 minutes at birth. But you keep acting according to how the baby is doing. You need to follow the action plan of Essential Newborn Care 1, which used to be helping babies breathe. It has been modified and it has actions, steps that help you to help this baby, individual baby. Looking at how you prepare for birth, how you dry thoroughly at birth and act. And if a baby is not breathing, you quickly clear the airway, stimulate, then help the baby to breathe before the end of 1 minute to provide care for this baby. Ensure there is warmth throughout, infection prevention, that is hand washing, a clean area where you're doing the rest, and the equipment you're using. And then continuous assessment of breathing, heart rate, color, and muscle tone. So what are the key messages? Scoring the baby and identifying the baby. You ensure baby is kept warm throughout, because a cold baby will take long to respond or will instead deteriorate and you will not achieve. Do a quick assessment of airway, breathing, saturation, and act accordingly. Like if the airway is not clear, ensure you clear the airway. If the baby is not breathing, please provide positive pressure ventilation, what we normally call bagging. Saturation will come automatically if you do proper ventilation. Then act according to how the baby is responding. And your actions will determine the outcome of the baby, not the scoring. So don't run to score, but act quickly. Assess the baby and act quickly, ensuring warmth. Thank you for listening.
Thank you very much, Dr. Agnes, for the wonderful presentation. And this has given us updates. I know we have learned a lot. We have got a lot. Most cases, we have been taking babies. At times we rush with the baby and we say, Africa score 7. But when you assess this baby in the NICU, you find the baby like has a Africa score of 3. So this is really very important. So you should note down your questions. We are going to continue with the second presenter so that we have questions at the end. So you can note your question down. So at this juncture, may I invite Dr. Jennifer Des Moines, pediatrician from Mulago Specialized Women and Neonatal Hospital. You are most welcome to give us a very wonderful update. You're most welcome. The question. Thank you very much, members. We have decided that you must ask the few questions because maybe some people may forget the questions so that we go to the next presentation. So you can either raise up your hand or you can write in the chat the questions pertaining the presentation which has just ended. Thank you. You can put up your hand or write in the chat. I see there are no questions. Maybe everything was. Let's now have the second presenter coming to present. Thank you very much. Doctor, you're welcome.
Thank you so much, Sister Agnes, for that presentation. So I'm Dr. Christopher Jennifer Des Moines, a pediatrician at Mulago Specialized Women and Neonatal Hospital. So I'm going to have 2 presentations. One, triage of neonates after birth, and the second one will be newborn head-to-toe examination. Maybe just a disclaimer, when we say head-to-toe examination, it's not that we are taking on the head, then looking at the neck, but just to let you know that these babies need to be examined. It even take you 5 minutes to examine fully a baby head-to-toe. So you don't just, it's head-to-toe just for easy examination of everything that concerns the baby, but basically you could look at the head while looking at the neck, while looking and tying up the findings. And also, someone can't hear me really well.
Percentage. Response.
So we are trying to make sure at least we do something so that everybody is hear this presentation very well. So just be patient a bit.
Yes, so I was saying that when we say head to toe, it's not that you're going to come from the head then to the toe, but you can actually look at very many things at the same time, because we also want to minimize exposure of this baby to cold. And as I also go ahead, I would like to also let you know that as we examine these babies, we really don't need to introduce infection to this baby. So we need to ensure that we maintain infection prevention and control measures while managing the baby. So as we note, neonatal mortality rate in Uganda has decreased from 27 births per 1,000 live births, 22 births per death per 1,000 live births. That's in 2022. And we are almost at our national developmental plan 3 target of 21 deaths per 1,000 live births. However, in Kampala, the deaths are more. This is data from the DHSI2 for about 9 months in 2022. And birth asphyxia is really still a major contributor of death. And immediate and appropriate inpatient care through health facility-based stabilization has been found to reduce deaths. And also access to quality health care, which every person really deserves, has been shown to contribute to reduction in newborn mortality. Our aim as a country basically want to ensure that we meet the SDG goal 2030 to reduce the deaths by 12 per 1,000 live births. That's why we ensure that these teachings continue, but also measures are being taken to reduce on the neonatal mortality. So this is the wrong presentation. That's the one I just sent on the money. Yeah, it doesn't mean the money. So some mistakes on this one.
Hello. We are sorry, we just wanted, there was a video which she wanted you first to watch, and that's what they're looking for. So just be patient. Within just a minute, everything will be well.
She's the one who's listening.
Yeah. We are sorry, but everything is now okay. We are going to continue.
Okay, it could, sorry, Winnie.
Hello. Just give us a few minutes, but we can be chatting. We had the first presentation as they organized the video. They are going to play the video, but the network is a bit disturbing. So anybody maybe with any question pertaining the first presentation, please, you can still go ahead, write in the chat, or you can put your hand up so that we can handle this and we save this time. Any question? Any comments pertaining the first presentation? Please, welcome as we wait for the video, to watch the video. In 1 minute, we shall be watching the video on newborn examination. We still don't have any question? Are you hearing us? Is it clear?
Yes, you are clear. We are hearing.
Oh, fine then. Okay, if there are no questions, no problem. Just give us like a minute so that you can watch the video. And we know this is a very essential thing, examination of the newborn. And most research has shown that we normally don't do it in our facilities. Or maybe we just do the quick one at birth. But ideally, we're supposed to examine all our babies before the babies are discharged. Before we discharge our mothers and the babies, we're supposed to examine our babies. I don't know whether we're doing this in our facilities as the guideline really stipulates. So that is why we thought this is a very important topic to at least update every health workers, not only nurses, even the doctors. These babies are supposed to be examined. And I don't want to preempt what is going to give us, but then we know for sure that we have very many things we examine from this newborn. It is not only the abnormalities. We know for sure there are many things, even as the health worker, sometimes we cause injuries by accident. So all this, when we examine this baby, we can rule this out. And I know you remember very well, at times we have those difficult births. The difficult birth where we even do a bit of clavicle fracture. And at times even a difficult delivery. Fracture may occur without even the mother knowing, or at times even without us, the medical people knowing, the midwife knowing that the fracture has occurred, especially at the clavicle in a very difficult birth. Through this newborn examination, that is where we identify this kind of problem. And we know this is one of the area of litigation. If we have not identified the mother and informed her that this occurred during this difficult birth. So this is very, very important. We should not ignore this. And it is one of the things we must do before discharge. So I think
Just 1 minute.
just within 1 minute, I think we shall be there. And I don't know whether in our facilities, are we doing newborn examination to all mothers? Are we doing triage very well to our babies? At times, yes. Do we follow first come, first serve only? Do we have those requirements, what we use for triaging these babies? Do we have all that in our facilities? So I think today we shall learn from here if we don't have. And yeah, we learn from here so that you can initiate in your different facilities. So thank you very much. We can now go back and take you back to Dr. Jennifer to take us through the video and all what he has for us. Thank you. Dr. Jennifer, you're most welcome.
Okay, I'm sorry for the technical niche. Okay, so today we shall do the triage and assessment of newborns. So, and then we also do, so in triage is basically you're sorting out a newborn who needs to stay with the mother or who needs to be resuscitated or taken care in the neonatal unit. So basically in triage, just say it's a newborn breathing. If yes, be with the mother. If no, this newborn is taken, so resuscitation begins or transferred to the newborn unit. And basically with the mother, it's just the essential newborn care that she goes on to be done. So the goals of then in the assessment, basically, you want to get baseline information about the baby, for example, the weight, the head circumference, has baby passed urine, has baby passed meconium. Also want to detect any occasional illness that the baby may have. And there are some babies who may just have minor deviations from the normal, and some could just be familial, like syndactylity, polydactyly, or birthmarks. So these mothers basically need assurance whether their babies are okay. And also we want to evaluate any developmental response in the NICU. For example, the case that we had, this preterm was taken to the neonatal unit, and then we wanted to see after before discharge, is the baby okay? And also some babies may have conditions that predispose them to neurodevelopmental poor neurodevelopmental outcomes. So we want to prognosticate whether these babies may get these outcomes. And also there are some parents who may have difficulty caring for their babies. For example, if they're alcoholics or they have poor socioeconomic backgrounds. I work in a community whereby some mothers come from the streets, and imagine after delivery, she has to go back to the streets. So here you may have to connect them to organizations who may need to help with things like housing or taking care of their babies. Then in newborn assessment, early intervention basically makes a whole difference, because some conditions like congenital cataracts, which is a major cause of blindness in children, if intervened early, you can actually stop or prevent blindness. Then other conditions like posterior urethral valves, which may eventually lead to kidney failure, if not acted on early, can actually be also found in the newborn assessment. Other conditions, if you've moved around with the streets, you see some adults or bigger children growing up with what is termed as a neglected club foot. So this could have actually been taken care of in the neonatal period, and the person sought care. There's some conditions like undescended testes. There is a 26-year-old after their wedding. They had issues with the conception, and then in the assessment they found that the man actually had grown with undescended testes. So this could actually be picked early and corrected. So in this newborn assessment, the yield of abnormal findings is basically high. A study done by Adam and colleagues in 2003 showed that about 20% of these babies could have one isolated anomaly. So if you look at this picture, this baby just has Erb's palsy. Then this one here, this baby just has Erb's palsy. Then this child, for example, it's very good to tie up the findings that you get in these children. So an isolated defect like Erb's palsy, then if you get maybe a syndromic baby like with Down syndrome, you have to tie up the findings to really get them. In Uganda, the congenital anomalies, a hospital study done by Mumpe and colleagues showed that they just had about 66.2 out of 10,000 lines. But it's good to really pick out these and also try to see whether it's an isolated anomaly or see if it's really a congenital anomaly. So when should these babies be assessed? So at birth, it's good to assess them at birth, as Sister Agnes highlighted, because then you want to really sort out and see whether they need just to do essential newborn care, or they may need to go to the NICU for further assessment, or you need to assess them further. And a more detailed head-to-toe examination should take place within at least the first 24 hours before the baby is discharged. And we need to differentiate between the spot-on examination at birth and the detailed head-to-toe assessment. And this assessment needs to really be done by a trained health worker, because we need to tie up the findings that you get in this assessment. And as we assess the babies, we really need to have time to speak to the parents or the caretakers about what the issue really is. We need time to talk. So one study showed that most mothers or caretakers preferred midwives to assess their babies, because they found that midwives give them more time to talk to their babies, and they find that, this is more satisfactory. So when we're assessing our neonates, we need to ensure that we speak to the mother, and then we need to make a sense of the findings. For example, if a baby just has, let's say, a syndactylity or joining of the digits, you need to see if there are any other abnormalities, or it's just a familial syndactylity. So there are things that we need, which are listed there: stethoscope, or thermoscope, pencil torch for the red corneal eye reflex, tape measure, bilirubinometer, documentation, and newborn personal health card. World Health Organization gives us a very good checklist for newborn examination. You could actually get that. Some considerations. The assessment basically is not really a perfect screening tool, but you need to really assess to pick out what needs to really be done, and also get the correct identification of this patient. Introduce yourself, fully examine the patient, head to toe. So as I mentioned earlier, head to toe, basically, you're not going to say, I'm going to first do the head, then I go to the toes, but you can do a quick assessment of the baby, and then you look at the things which may need to be picked out from the baby. And if baby is sleeping, please do not wake the baby up. You cannot examine the baby even when sleeping. And you keep the hip examination really last. And if you look at the case presentation, we took history. It's very important just before the examination to know the history of the mother, for example, obstetric, social, because, for example, if a mother had congenital let's say toxoplasmosis or syphilis, you can actually get to know and see, get to pick out those which may appear on the baby. And observation alone, we shouldn't really keep touching every baby because they get irritated, and then also preventing infection. So observation gives very valuable information, especially on CNS. Actually, if you observe a baby critically, you may not even need to really do a full CNS examination for the baby. And also, we need a warm change to prevent heat loss. Conduct the examination in a warm area, basically away from droughts. Use a radiant warmer or warming lamp. And then for babies who are inside incubators, please keep them there, and also avoid stimulation and agitation, especially for these preterms. Stimulating and agitating them, you see the heart rates going up, getting distress. So avoid stimulation, agitation, and provide a quiet and calm environment as much as possible, and also gentle handling of these babies. Good hand hygiene. Also consider family involvement. Ask about any parental concerns, and also encourage participation. So head to toe, basically, history, as I mentioned earlier, is very important because you're going to get so many things. For example, just asking, wait, did you have any infections? Did you, what's your blood group? That's for jaundice, any maternal and paternal concerns, gestational age, which is best got at 15 to 19 weeks in ultrasound. Our case, the baby, we did a ballot to get the gestational age. Delivery complications, for example, during delivery, was it a difficult delivery? For example, if a baby had Ox palsy, post-delivery, what were the scores? How was the baby post-delivery? Then for the skin, you note that the skin, basically, when baby is undressed, you can see how the baby is for cyanosis. If in doubt for cyanosis, for example, you can use a pulse oximeter to get the correct SpO2 of the baby, any pallor, jaundice, skin texture. Are there any macules or papules? And some babies may be born with pustular lesions. So you pick out those babies to really sort to get the right treatment. So for the head, so see the disclaimer, I'll just mention that sometimes you look at head to toe. So look at the baby has a hole. Yes, I'll go head to toe just for us to know, but you can examine this head to toe basically at a go and just note your findings or significant findings. And as noted, most babies, their heads are distorted during molding in labor and delivery. And so we should differentiate some malformations from mechanical forces. So this baby basically just had a caput, while this one here, so this one is just a caput. This one here is a malformation where there is a joining of the cranial sutures. So you should differentiate those. The anterior fontanelle should also be looked at. Usually it's about 3 centimeters by 3 centimeters in the largest diameter. Look for any fullness or bulging. So basically what we are doing is to look for this and then try to, as much as possible, we're going to try to tie up the findings to see which babies need to really be picked out. So look for craniosynostosis. So in this first picture, so craniosynostosis, basically, some babies are born with joints, joint sutures. So if got early, you can actually do cosmetic surgery so that the head grows proportionately. So it's very good to pick out this so that you send them to the right specialist to really help with the baby. And also differentiate benign swellings. The first picture has shown you a baby with just a caput, but these ones here, some of these swellings like subgaleal hemorrhage. This baby deteriorate very quickly. So try to pick them out. And you see from history, if a baby comes with subgaleal hemorrhage, then you're going to see that this baby probably had a very difficult delivery. Some had a forceps delivery. So you need to pick this up. Then also like a cephalohematoma on one side, just to then cross the suture line. So picking all these babies will help us basically to see, because if a baby has a cephalohematoma, you just say this a benign swelling and will disappear, while a subgaleal hemorrhage will need admission, may need blood, may need fresh frozen plasma, and so on. And then sometimes, if a head is just small, it could be a familial, but some congenital syndromes or congenital infections can cause a small head. A large head could also be a congenital megaencephaly or a hydrocephalus. So you just need to pick out these to ensure that the babies are managed appropriately. Then in the face, basically, I'll just keep emphasizing this, that we need to, I'm doing the head to toe, but look at the baby, just has a hole, has to examine the baby, and just pick out most of the things. So for the face, newborn babies basically have unremarkable faces. If not sure, just look at the parent. Sometimes you may just get a true resemble this parent or this other parent, but also the face can be a first clue of a congenital abnormality. Let's look for other associations. So when you get an abnormality, try very quickly to look at what associations they may be having. If the baby looks normal, basically, they could just have a flat nasal bridge. Maybe in their family, it's just a flat nasal bridge, and there is nothing else. Have a quick glance on the parents and see, maybe one parent has a flat nasal bridge. Or sometimes a baby may just have facial pulses. So a facial pulse, you have to differentiate it from absence or defects or hypoplasia of a depressor anguli or wrist muscle. So you've seen some babies. We had a case where I was working earlier, and this baby is calm, like very okay, when quiet, but once they cry, they get this kind of abnormality. So this is basically hypoplasia of the depressor anguli or wrist muscle. So this one here is usually they require treatment, but the mother may really be concerned. So we need to talk to them and say, with time, this will disappear, or as they grow older, it's not really significant. While a facial palsy, sometimes when there is compression or pressure in the stylomastoid foramen, where the facial muscle exits the temporal bone, then they may get a facial palsy. So this should actually be differentiated and taken to the right person. Then this baby here, you see this face has micrognathia, has low set ears. So pick out these babies, always try as much as possible to tie up the findings for this child and do the necessary investigation. For example, most of these babies with abnormal fascias may also have a congenital heart disease. Then the ears, look at the ear shape, size, position. This is basically a normally developed outer ear. This is an abnormal ear, the position is abnormal. So, so try to get, look at the syndrome. What syndrome may this baby have? Are there any other things? Does baby have difficulty in breathing? Could there be a congenital heart disease? So try to pick out all this from the baby. Then the nose, general shape and the width, try to get it comfort distance, about less than 2.5 centimeters. If you look at this baby here, this really a cute baby. Really cute, just has a wide nasal bridge, So, and then there seems not to be any other abnormalities on this baby. So sometimes, if in doubt, compare with the parents, but also if in doubt, just has a flat, it's just one abnormality that they have. So try to look for others. If there is nothing, you could, and parents are still where you could go ahead to do probably an echo. Just to ensure that there is no other abnormality. Then if you look at this baby, just has a flat nasal bridge, just like this cute baby. But then has low set ears, has micrognathia, has a tongue protruding, has a light tongue. So try to tie up these babies. And then sometimes because of a difficult delivery or some pressure during delivery or pregnancy, they may have a dislocated columella, just like this baby. So this may need to be surgically corrected. So you observe and just take them to the right person. Complete nasal obstruction can also occur. So these are babies who may ensure patency of both nostrils. So you don't go on fixing catheters on the nose of every baby. So if there's a distress and you suspect there is a complete nasal obstruction, then you could fix on a fine catheter to ensure the nose is patent. Then eyes also. So as I continue with this, I'll just keep emphasizing that, take up the findings. It's not that you're going to look at the eyes, that you look at the baby as a whole. This is just for the presentation. So inspection, the size of the eyes, dimension, is there strabismus, nystagmus, exotropia. It's basically if there is it's really a transient condition, while esotropia is abnormal. Then is there any eye discharge? So most of these babies, basically, some babies have a discharge. If it's really colorless, mucoid, this usually go. But if it's a purulent discharge, did the mother have gonorrhea, for example? If it's a purulent discharge, so we need to pick this out as well. Then those who have attended to newborns, you see that some babies are born with subconjunctival hemorrhages, and it worries mother so much. It might be the baby bleeding in the eye. So we need to assure this is a transient condition, it will disappear. So that's why talking to the baby so to the mothers is really very, very important. Jaundice can be looked at a glance, also compare with the history. Is there ABO incompatibility or recent incompatibility? And then this baby here, this last baby here, if you look at this, I just has a dacrocystocele. This is basically an obstruction in the lacrimal gland. So most of them are really membranous, but refer them for opening up because it can get infected and they get a dacrocystitis. Then the iris and the cornea as well, you need to look at it really critically. Some babies may have this is a coloboma, a keyhole deformity, very common in some congenital torches, but also baby mothers who may take alcohol. Then aniridia is absence of the iris. Look at the cornea for any cataracts, because as I mentioned earlier, for any cataracts of the baby, we need to really pick it up because you can actually prevent blindness in this baby, and then also it aids quick referral to an ophthalmologist. Then the mouth, basically, the size, is there a small mouth, is there micrognathia? Look at the symmetry, inspection, basically. You're going to look at a lot of things. I'll look at the mouth, a few things on the mouth, just to point that out. Some babies just have, if you look at this is a very common thing in babies, the Epstein pulse. And if you are in an upcountry setting, even our setting here, because I remember when I was an SHO about 5 years ago, we received a baby who had actually been born in one of the big hospitals in Kampala, just had an Epstein palm, and they were taken to see a dentist. They tried to break it up. The baby actually came in shock, like had bled a lot. So these are things you can assure the parents that it's okay. And in our other settings, people call it a false teeth. So we need to really ensure and tell the parents this is a transient, and in a few weeks it will disappear. So we need to look at this. Then natal teeth is also common. So some babies are born with natal teeth. So also getting them to assure the parent that this one here should be removed, especially if it affects feeding. The dentist can remove it. Then another condition is a short frenulum, which is a tongue tie. If it really doesn't affect feeding, if baby is feeding well, I believe this can be, it doesn't need to really be acted upon. And then cleft palate, cleft lip. If you get someone with a cleft palate or a cleft lip, Then look for other abnormalities also because cleft palate has been assessed with a Catch-22. Then also sometimes isolated cleft palate, they could be having an ASD. Okay, and the neck, is it short neck? So basically, if you're looking at this, you need to try to tie up the findings, whether it's isolated or there's a syndrome that needs to be looked at. Sometimes babies may just have lumps, a web neck like in Tanya, a very short neck, redundant skin posteriorly, like here, in Down syndrome, and then some babies are born like with a cystic hygroma. Then you see this baby has having a short neck. Look for the other things which are there to tie up the syndrome, so that you can actually look at the baby as a whole. Then some may have tumors, then palpate for the clavicle as well, especially if there is a difficult delivery. And if there is an Erb's palsy, look at the clavicle. There could be a fracture in the clavicle. In the postnatal clinic, we've had some babies actually come with a fracture of the clavicle, or some after 2 weeks or then 6 weeks, they come with a swelling on the clavicle. Then when you do an X-ray, you find that probably we could have missed it out, and then it has actually healed, and baby now has a deformity. So it's very good for us to look at these things in the first 24 before the baby is discharged, so that we can act on it. Then the chest, basically, the screening or the assessment may not detect many congenital heart diseases. Actually, one of the studies shown that neonatal checks, they fail to detect more than half of the congenital anomalies. And babies, when they are delivered, they may have a bit of some cyanosis. So here we look for cyanosis, shock mama, and babies who are very sick usually. This has been picked on in the initial assessment of the baby. So we look for any breast swellings. So sometimes a baby may just have a breast swelling, and mothers are so concerned about it. So telling the mother, this one is a transient, it will disappear. Just look for if there's any inflammation when they come back. If they're cyanous, if in doubt, then just get a pulse oximeter, look at the rates, signs for distress, the baby syndromic, and then respiratory pattern of the baby. Or there's some babies who may require resuscitation, but they stabilize. But if you review them after maybe at 24 hours, you find there's still a bit of distress for these babies. Chest. Then sometimes you really have a normal or a stable baby. Like, it's okay. You may not even need to really go to listen to the chest and the heart already, because baby is okay, though you could. And if you listen, you may get some innocent mamas. And if echo or a chest X-ray may really differentiate. And when I'm bringing up this, sometimes if you hear a mama, it could be an innocent mama telling the mother or the parents that there's a hole in the heart, it causes great anxiety to them. So hearing it, try to explain if it's an innocent or a significant mama, and also give them a plan on what you really want to do. In abdomen, usually the major abdominal wall defects are detected either prenatally or in the initial scans, and inspection basically gives very valuable information. Look at the cord. Is it bleeding? There are some, sometimes you may see it hasn't been indicated when a baby is bleeding, and sometimes it's just probably an umbilical cyst or granuloma or hyperemia around the cord, which may actually be a sign of an infection. It's very good to pick this out also. Then the genitals, we need to examine the genitals. I told you of that case of a 26-year-old who at 26, when he could not actually, they had issue infertility, then realized that probably he missed out at descended testes. So that's very good to sometimes really look through and see. Then also hypospadias. try to look for it. So this basically will help you to see, to help the baby early, and then it's sent to the right subspecialists. The genitals as well, look for ambiguity, look at the anal position. There are some babies actually who have been discharged with an imperforate anus, and you know, we have examined or we have delivered these babies. So we need to really look at that. And also genital ambiguity. Because if there's an ambiguous genitalia, these babies, most of them actually die in the community because of electrolyte imbalances, hypoglycemia. So it's good to pick them out and try to investigate and ensure that they are properly managed and properly referred before discharge. The spine as well, obvious spine defects usually are detected prenatally, but if they could just be a tuft in the skin or a dimple. So if in doubt, just do an ultrasound to ensure that there is no spinal bifida that we are missing. Then the limbs as well, both the upper and the lower limbs need to be examined. As I mentioned earlier, if someone just has an isolated extra digits and there is nothing else. So this one here, you will be able to try to just assure the parent that, you know, this can be ligated, or if there's a bony prominence, it has to be disarticulated. There's probably Erb's palsy also. This means this baby may need physiotherapy. So observe for the hand movement and for any pulses that may be there. And just to emphasize again, we need to keep tying probably this baby has an Erb's palsy. Look at the clavicle. This baby has an extra digit. Is there any other abnormality? This baby has syndactyly. Is there something else that we need to really pick out for this baby? Look at the palmar creases. Is it an isolated palmar crease? A study has shown that among the Chinese population, most of them just have an isolated palmar crease. So look at it. Just say, don't just cause unnecessary alarm. Look and keep tying the findings. And the hip examination should basically be the last because it irritates most of the baby. The Ottolani-Barlow maneuver is really difficult to describe, but I don't know which centers we have in a baby hippie, which is easy to demonstrate how to do it because, but however, if there are babies with risk factors for developmental dysplasia of the hips or congenital dislocation of the hips, so risk factors like probably a parent a first-degree relative with childhood hip issues, breech after 36 weeks, other risk factors like talipes, oligohydramnios or torticollis. So if these babies have these, then you try to do an ultrasound scan to ensure that you don't have a congenital dislocation of the hip or developmental dysplasia of the hips. So general considerations, most preterm infants have quiet and active sleep. The bodies are usually flexed. Spontaneous motor activity can be used to examine the tone and the strength. And now, like the tone, touching the baby who is sleeping can really irritate them. So just looking at how the baby is moving, you can actually get the tone and the strength. Then crying, look for excessive crying or high-pitched crying or a very weak cry. Sometimes a baby may have been resuscitated and improved, then taken to the mother, but the cry is really weak. Try to tie it up. Is baby feeding? So get all these things while we take care of the baby wholly. Then excessive crying is basically, and so you're trying to do everything, but baby is not really keeping quiet. Then also feeding and suckling patterns can be good. And after all this, be ready to give your education to the baby, to the parents. So in conclusion, neonatal assessment needs to be done at least in the first 24 hours or before the baby leaves, and make sure that you make sense of the findings. So if you have a cleft palate, for example, or a cleft lip, for example, is there any other association? What are the things which can be there? Is there congenital heart disease? Is it part of the patch 22 defects, cleft palate, thymic hypoplasia, cardiac defects, abnormal fascias? So make sense of the findings and also be ready to educate the parents and manage for a proper planning, manage appropriately or plan for a proper referral to the right subspecialist. So hospital policies, so recommend hospital policies and protocols need to be there to really get to see that every baby is assessed before they leave. This needs to be written and taught to the healthcare workers, and trainings like they are doing is important to ensure that we get the importance of assessment of these babies, and also that everyone knows how to assess the babies, and partnerships. Sometimes you don't have the necessary things to try to assess the babies, so getting partners to help issue with training and equipment you may need is also very important. So we need to keep the dream of our babies alive, ensuring that the mother knows and is sure that baby is okay. These were really my references. So even as I end, I'll just like to restate that it's all our responsibility as health workers taking care of babies to ensure that the mothers are first of all satisfied. Yes, the initial assessment has been done in the neonatal, in the delivery room or in the theater. So it's now the assessment. You want to pick out these things because these babies, as well as they are healthy, they should be kept alive, but also thrive at the same time. So it's all our responsibility to make sure babies are well assessed and the right referral pathway is followed, so just in case. Otherwise, thank you so much for listening.
Oh, wow. Thank you very much, Dr. Jennifer. I think it has been wonderful. And really, we have taken a lot of, we have been updated also. For sure, with our babies, we are supposed to examine our babies. He has told us. And if you remember what he said that you have to be trained to be examined this baby, so that you can identify any deviation. And also emphasize on giving the feedback to the mother after examining, or to the caregiver after examining this baby. And what I want to emphasize again is that these babies are always examined in the presence of the mother. We don't examine this baby alone without the mother's consent. The mother should be there present, and also it should also be done in a very, in a room with good light, so that you don't miss anything in that room or on that baby. So this is very, very important. Thank you very much, Dr. Jennifer. And now we still have question session, question and answer. So I feel maybe I first give Dr. Idris opportunity to answer some questions which are on the chat. Dr. Idris, from a consultant pediatrician from Kawempe National Referral Hospital. I know you are online. I request that you unmute and you answer the questions which are on the chat. And maybe we shall also ask other questions after that, in case you have any question. If you don't have any, then we shall continue and we ask new questions. Thank you. Doctor, you're welcome.
You need to note here, calls.
Doctor, are you there?
Excellent.
Dr. Idris? Okay, maybe we can continue. You may answer that later. You can be compiling and you will answer those questions in the chat later. So the session is again open for questions, and we shall see how to answer them. Please, any question, you can put up your hand or you can write in the chat. Then your questions will be answered. Thank you. Hello. I hope we are together. Can you hear me clearly? Hello? Yes. So I was asking you to write maybe any question on the chat or put up your hand. And in the chat here, we have one question. I think Doctor has been answering some of the questions online on the chat. Most of the questions have already been answered. But we have this particular question. There is somebody who has just given, some comments and said, thanks for the wonderful presentation, Doctor. Well done, team. And there's this one question. Do we have a comprehensive score on how to assess nervous and muscular system in neonates? I repeat. The question goes, do we have a comprehensive score on how to assess nervous and muscular system in neonates? So, Doctor, do you want to answer this question?
Thank you so much. No particular score that I can think of, because as I mentioned earlier, usually you can get a lot of things or information about the neurological system of the baby, right from history, right from feeding, right from the cry. So you pick a lot, and also you may not need to touch the baby actually when doing a CNS examination for the baby, because you'll be moving. The tone, you can look at the tone just by the movement, or if baby is floppy. However, I looked at a WHO checklist. You can check it out in the net, which gives you individual things of what to look for for the CNS, but also the general checklist for assessment of the baby. You can look at that. It's available in the net. I think it's 2019. That's the latest we have. So you can look at it. But for CNS, basically, you can pick out a lot of things just by mere observation. Has to do the other things for the baby. And as I mentioned earlier, touching the baby, infection, and the whole thing of agitating the baby creates a lot of discomfort. So if you really want a more detail, I've seen a WHO checklist of the assessments, which can actually be got from the net. Thank you.
Thank you very much, Dr. Jennifer. I hope your question has been answered. Are you satisfied? I see a hand up. Esther Martha, you can, you're already unmuted. You can go ahead and ask your question.
Good evening.
Good evening.
Well done, team, for the presentation. Now, I wanted to go back to Sister Agnes's presentation on how to score the babies. And I look at a situation, I am a nurse working in neonatal unit. The APGAR score, actually the first minute, that one golden minute, the baby is with a midwife. I may not be there at that exact time. They have used the APGAR score, they have scored the baby, probably they have brought for me the baby. And looking at the presenting the way the baby is presenting, let's assume the baby is having asphyxia. So they have told me the baby scored like this. But to me, on first examination or assessment, when I see this baby, I don't trust the APGAR score. Do we still use that very APGAR score, or there is another means we can assess this baby and draw out our own APGAR, score for this baby?
Thank you very much, Esther. Agnes, do you want to answer this question?
Yes, please, Esther. Thank you for that wonderful observation. Most of the time, we are appealing to the labor midwife to objectively score the babies, because if they subjectively score the babies, they will hyperscore or underscore. And as I elaborated before, I emphasized that somebody who knows what to do, how to do it, will do. But we are looking at a score at 1 minute, a score at 5 minutes, and I'm asking Esther, at what time has this baby come? But when the baby has reached the neonatal unit, and the score is maybe higher than what you see, you re-examine, as Dr. Damwe has just told us, examine the baby, neuromassage and arrest, and you can rescore this baby at the minutes the baby has come. Then you'll be able to score on admission. So you still look, but the best would have been at 1 minute, 5 minutes, and you are able to care for the baby. But we appeal to the midwives to objectively score these babies after drying and keeping the babies warm, and do that quick assessment. Thank you.
Thank you.
So thank you very much, Agnes. Maybe Dr. Jennifer, if you have something to add on, you may also give your submission. Thank you.
Okay, thank you so much for that question. So the APGAR score, you need to reassess the baby has transmission, but sometimes the baby may have a progressive illness. So there are other scoring systems that you could actually use. For example, I think the score, you're basically looking if the baby got asphyxia. So we do probably a Thompson score just to assess and ensure that baby is okay. Because the basis of it all, you want to ensure that this baby is actually fine and able to either stay with the mother or get the correct things. And sometimes a baby may have scored low, have a good score, but then by the time they go to the neonatal units, maybe they haven't fed for some time, maybe the postnatal, and baby just has hypoglycemia. So we try to get out some of the metabolic causes of what the baby may just look deep. Another example, this sometimes, yes, it's a poor scoring because of some reasons, but also sometimes you may have a baby who has scored actually well. But the issue could be maybe has a congenital abnormality, which has now, or heart disease, and then is now getting cyanosis. There's a baby who was delivered and scored actually well. Scored, I think 7 and 9, but they came to the units, and then baby seemed to be deteriorating. So the question was, is this a correct score for the baby? So resuscitation actually after the probably 20 minutes or so, baby wasn't improving, and actually we lost that baby. And good enough, a postmortem was done. The baby had bilateral hypoplasia of the lungs. So the score, sometimes yes, it's a poor score, but sometimes look for other things that the baby could be having other than just issue of asphyxia. Thank you.
Thank you very much, Dr. Jennifer. I think this is very clear. This baby can also be scored, and she has also emphasized that we can even use the Thompson score, and we score this baby. So I think most of these facilities have this Thompson score. We should be having them, and we use them really to help us assess our babies. So do we have some questions? Maybe if you have any question, you can put up your hand. If we are done with question in the chat, do we have any question in the chat? I don't see any question in the chat. And I don't know whether Dr. Idris is around. Maybe you may want to say something. Idris, if you're around, you can unmute and say something before we summarize our session today.
Okay, thank you. Thank you very much for this opportunity. Thank you, team, for the presentations. They are great presentations and insightful, as I've seen in the chat. Maybe just to highlight some of the common questions I've been responding to in the chat. They are actually relevant questions starting from the case we had. I don't know how much time we have, but there are about 10 questions, if time can allow, and I briefly go through them. Do we have enough time? 10? Yeah. Okay. Let me. Hello? Can you hear me? Let me try to be brief. I think one question was emphasizing. One question, one of the members asked why we discharge babies on Hemofort, and I tried to explain in the chat that the Hemofort contains iron, and the prematures have low iron stores, and that's why we have to give them iron to boost up their iron stores. And then someone wanted to know how we classify low birth weight. There are 3 categories. Low birth weight is below 2.5, but up to 1.5 kgs. Then very low birth weight, those ones are below 1.5 kgs, but at least 1 kilogram. And then extremely low birth weight are less than 1 kilogram. The other question was about, someone was concerned, can we really discharge a baby who is 72 hours old on Hemofort? And I answered that, according to the guidelines we follow, the baby can start Hemofort at discharge. By Hemofort, I mean, its equivalent. At discharge or at 1 month postnatal age, whichever comes earlier. If the discharge comes before they make 1 month, you can give them Hemofort. There was a question on ideal weight for discharge. Babies who are above 1 kilogram can be discharged if they are clinically stable and they meet the other parts of the discharge criteria, which I think has not been in our scope today. And when do you stop scoring babies? That one was answered by different people. I also answered. we stop APGAR scoring at 10 minutes. So it's 0 at 1 minute, 5 minutes, and 10 minutes. The seventh was which criteria do we use to say that this baby is large for gestational age and this baby is small for gestational age? There may be simplified criteria, but the one which is commonly used, we use the WHO charts. Each gestational age has corresponding weight percentiles. So you look at that chart, if it's above 90th, you can give, that baby is large for gestational age. If it's below the 10th percentile, that is small for gestational age. The commonest causes of neonatal mortality, that one was highlighted. We have birth asphyxia, prematurity, and the neonatal sepsis. Those are the commonest causes of neonatal mortalities. And then there was a question on whether congenital heart defects in Down syndrome can resolve on their own. This one, it's less likely because the common congenital defects in Down syndrome, if they occur, they actually involve that entire septum. But if it's a small defect, that one can resolve, but you need to follow up the baby. Last but not least, if our baby has Erb's palsy, why should you refer the baby? Is there any special treatment provided at referral sites? I don't know whether I can call it special, but the main management we provide is physiotherapy. But you need to assess the extent because the management may depend on the extent of the palsy. This is palsy damage to the nerves which supply the arm, and it's mostly caused by birth trauma. Then the issue about return date, I didn't commit myself because different centers recommend different return dates. This is the last one. For example, where I work, we give pretty much as a return date of 2 weeks from the time we discharge them. The standard may be 1 week if you are not so congested. And so I want to leave that to the different health centers to work it out. So basically, I think I've tried to cover the common questions that appeared in the chat for those who didn't see the responses. Thank you very much. Back to the team.
Thank you very much, Dr. Idris, for that elaborate discussion. We are now coming back to the presenters. I would like to request Sister Agnes to just give a take-home message to the audience, just within 2 minutes. Take-home message to the audience. Thank you, Agnes.
Thank you, Alice. Thank you, team. Thank you, everyone who listened in. My take-home message to everyone who is taking care of our newborns at birth. We should ensure, all of us, that we prepare for birth. Be ready, be skilled, be there to do our best for better outcome. Do a quick assessment when the baby is out, that is airway breathing and saturation. And then, as you score the baby objectively, looking at the things, all summaries are elaborated in the table, and not subjectively to excite the mother, as this will affect the outcome and well-being of the baby. And lastly, APGAR score is not what will determine the well-being of the baby, but what you see will help you to take actual care, prioritizing that the baby is breathing well. And thank you very much, everyone.
Thank you very much, Agnes. I also would like to request Dr. Jennifer also to give a take-home message to the audience.
Okay, thank you so much. My take-home message is basically it's our responsibility as people who take care of the neonates to reduce this neonatal mortality, which is contributing to more than half of the childhood mortalities, basically. And we need to triage, basically, sorting. We are picking out babies who just need essential newborn care to be with the mother, or babies who may need further management in the NICU and babies who may need further referral. And in this further referral, it's our responsibility that even when we save the lives of these babies, even when we save the lives of these babies, we have to make sure that they have a good quality of life. I think in the next few years, I really don't want to move in the streets to see someone who has a neglected club foot, which could have been corrected at birth, or someone blind because of a congenital cataracts. Then assessment, basically, it's head to toe, as I mentioned earlier, but you're not going from the head, the eyes, the nose, the ears, the neck. No, you're looking at the baby as a whole, because you should also be mindful, not agitate the baby, be mindful to not cause hypothermia or to cause infection. It's really an overall assessment, and after assessing, try to tie up the findings. If it's an isolated, for example, an isolated probably cleft palate, or try to tie up the find to really get what the baby has, and then not also cause unnecessary alarm to the mothers. Also make the correct referral and continue reading and practicing these things, because it should not take you a very long time to fully assess a neonate. Thank you.
Okay, thank you very much, Dr. Jennifer. The audience, we are requesting you again. You had a pre-test. Now we have the time for post-test. Please, we request you again to fill the form, and then it shall be done. But don't leave. We are going to have at least some snack. We are going to have, we shall request you again after finishing. We have one activity to finish.
It's in the form.
So you have 2 minutes to fill this form, and then we shall close it with one activity.
So they've shared the results. Right? So that's kind of just for the correct answer.
Okay.
I request Dr. Jennifer now to take us through the correct answers for the question. Thank you, Dr. Jennifer.
Okay. So the post-test triage, A was so A was teaching mothers to breastfeed. B was sorting babies who may require additional support. C was teaching mothers kangaroo care, and D was testing midwife skill. So the correct answer. Okay. So most of us got the answer correct. So sorting babies who may require additional support. Thank you. The number 2, neonatal assessment aims at the following, except okay. So we're supposed to get the single most correct answer. Getting baseline information about the baby, that's correct. Things like weight, height, head circumference. Then also reassuring parents about minor deviation from normal. For example, if there is, that's also one of them is correct, because then you're going to assure if it's just probably a familial abnormality, then identifying parents who may have difficulties caring for their babies, okay? So the except was to test lead biopsy. The other three were all correct. And I think more than 50% got the correct answer, and I hope you can now answer it correctly. Then when should assessment be done? About 99% of us got it right in the first 24 hours of life. Yes, thank you so much.
Wow, thank you very much, Dr. Jennifer. I would also like to thank the Ministry of Health, the Child Health, Reproductive Child Health, and also the Seed Global for this opportunity, and for the second Heart of Birth session, and others will continue. So this is now the time for taking the photos together. I request everyone to turn on their cameras and we take groups together. Turn on your cameras so that we can take a group photo, everyone. Photo time.
Karen is wanted to see the team members quickly. All of us see.
Oh, that is Eunice. Eunice, yes, we can see you clearly.
So fine and clear, we put on our whole screen.